This is an honor to have the Vollweiler Lecture. This is an annual event recognizing Wade Vollweiler, who is the first division head of gastroenterology, was the division head for 31 years. Hard to beat that. He was had a lot of research interest in hepatitis, celiac disease, nutrition, and metabolism. He was actually the president of our 3 major GI societies, including the American Association for Study of Liver Disease, the Western Association of Physicians, and the American Gastroenterological Association. And this is an endowed lectureship in his honor. And this year, I'm very pleased to present Dr. Lynn Chang. Lynn is a professor at UCLA, and basically has been here almost her entire life. Although I realized in her CV, there was one little blip. She did her undergraduate work at UCLA in biochemistry, medical school residency, and GI fellowship at UCLA. And then she escaped for a year at the Mayo Clinic, where she was noted to be a motility expert, even though her research focus actually was on gallstone pancreatitis at the time. But that was a good move, because she is clearly a recognized national and international expert in the pathogenesis and clinical management of patients with functional GI disorders. She's been on many of our national societies in terms of working groups and task force, was the director of our clinical congress for the AGA, currently on the AGA China task force. She was the director of an AGA single topic conference in IBS in 2015. She's a NIH term member of the study section on integrative and molecular gastroenterology. And probably most important, she's the a board member of the Rome Foundation. The Rome Foundation really is the dictionary of how we define and how we characterize all the functional GI disorders. And she's been on that group for many years. She's also the Education Committee Chair and the Rome 4 Editorial Board of Functional Bowel Disorders Committee. As you can tell, her research focus is really in functional GI disorders and irritable bowel syndrome in particular, some of the molecular and neurobiological mechanisms, as well as the clinical management of this difficult disorder. She's got a multitude of NIH grants, industry funding. She's, I think, about 360 invited national, international lectures, over 100 papers, and many works in a whole variety of journals, including gastroenterology, neurogastroenterology, and I saw one in psychoneuroendocrinology, which I didn't know was a journal, but because it's a melding of several different specialties. Tonight, she'll be actually speaking with us, this is a little plug for tonight, at our Pacific Northwest GI Society on the emerging treatments for IBS and bloating, which sounds interesting, but to us, it actually is critical, because bloating is something that you guys all send lots of patients for us to take care of, so I hope to hear a lot about that. Tomorrow, at our Frontiers meeting, she'll be talking about the role of the brain-gut interactions in chronic pain and stress of IBS. But today at Medical Grand Rounds, I'm pleased to introduce Lynn, and she'll talk about integrating scientific evidence and the practical approach in the management of irritable bowel syndrome. So Lynn, thanks so much for coming.
Thank you. Thank you, John, so much. I'm silencing my phone because I was looking at my purse thinking, how to do that. Thank you everyone for coming today. I really appreciate it, and I really want to thank John for inviting me. And I was reading about Dr. Vollweiler, and I thought what was interesting is that his endowed visiting professorship was actually due to the donations of all his trainees. And that's especially important to me because I'm the fellowship training director at UCLA for GI. And the trainees were very important to me, and I think that was really an honor for him. So I'm going to talk about integrating scientific evidence and using a practical approach. So when I take care of IBS patients, and I tend to have more of what people call the industrial strength IBS patients, but what I do is I really think when I'm listening to them, I'm thinking about physiologically what I think is happening with respect to brain-gut axis, and also I'm thinking psychologically, which is biologic, and I'm trying to put it together and try to create a picture and what I think is important to the patient. Okay, so this is my disclosure. Okay, so like Dr. Inadomi mentioned, we have the Rome board, and the reason why we had to develop these symptom-based criteria is because there was a collection of many patients with chronic GI conditions that weren't due to cancer or inflammatory bowel disease or reflux disease, but they had multiple symptoms, but there was no biologic marker. I feel like I'm having feedback. Gosh, I don't know how to do that. Oh, okay, thank you. So the symptom criteria were made to help, in a cluster analysis, identify these different groups of individuals who had these symptoms, like functional constipation, IBS, where you have pain and altered bowel habits, functional dyspepsia, where you have upper gut pain but no bowel habit abnormalities. And the reason why this was done is to help diagnose it, but also to be able to study it. So you need a relatively homogeneous group of patients to understand the pathophysiology and the treatment. So that's the reason why, and bloating is actually not in any of the criteria except for one. And the reason why is 90% of patients have bloating. And so it doesn't help discriminate conditions, but it's an important symptom. So we use the term functional, which means no structural, biochemical, or anatomic abnormality, and everyone really doesn't like that term because it sounds idiopathic. So our new Rome 4, which just came out in May at our meeting, is due to, we defined it as a group of disorders classified by GI symptoms related to any of these combination of physiologic abnormalities. So motility disturbance, visceral hypersensitivity, altered mucosal and immune function, altered gut microbiota, and altered CNS processing. This just shows that these are multifactorial conditions. So I want to take you through this conceptual model for IBS, and this is the way I think when I see a patient. So I think on the left, what are the vulnerability factors that increase a patient's risk or likelihood to get one of these conditions, particularly IBS? So there's probably a genetic predisposition. I'll show you a little bit of evidence for that. And it's always an integration with environment. This is either learned behavior, early life adversity, multiple illnesses, and other precipitating factors. And then it leads to, finally, a dysregulation of the brain-gut axis. And that leads to altered sensory processing. So the way that you perceive what's happening in your body is enhanced or altered. It could have psychological disturbances that could be pre-existing or worse after or developed because of them. GI motor disturbances, visceral hypersensitivity, immune dysfunction, serotonin, all these different mechanisms. Now, once you get the condition, then once you have the symptoms, then you have triggers. And they could be food, stress, which are the two big ones. And then the symptoms will determine how you seek healthcare and what your quality of life is. So let's just talk about what are the vulnerability factors to lead someone to be at risk for IBS. So there's been some identical and non-identical twin studies that have shown that there is genetic liability, but the genes probably add a little bit to the variance of the phenotype, but there is, with these twin studies, shown to be a genetic component. But this is a study done by Rona Levy here that I always show still, even though it was in 2001, because I think it makes an important point. And the point is that they had non-identical dizygotic and monozygotic twins, and they looked at the concordance of IBS between the twins. And there is a greater concordance with identical twins, which share 100% genetic material versus dizygotic, which is shared 50%. But the interesting part is when they looked at the mothers and the concordance of mothers with IBS and the children, where they shared the same amount of genetic material, it's pretty similar, and it's even a little higher than what you see with the twins. So what that told you is that even though there is a genetic component, the environmental component is probably stronger, if not as strong, as with the genetic. And so there's probably some learned behavior, or there's some other factor in environment that influences someone to get IBS. And there was a recent study, it's a Swedish case cohort, where they looked at first to third degree relatives and look at spouses, and they looked at the concordance, or what increased your risk, your increased risk for IBS. So if you look at first degree relatives, it's almost a two-fold increase if a first degree relative had it. A second degree relative, it's a little bit lower, but interestingly, it's a higher risk if your paternal half-sibling has it, not your maternal half-sibling. Then, of course, with the third degree, like cousins, which I think is 12.5% genetic material that's shared, it's less. But what's interesting is your spouse if you have a spouse that has it, there's an increased risk, higher than one of your relatives, where, unless there's inbreeding, you should be sharing genetic material, which happens, but I don't think it happens in Sweden. But also, and I don't know if it's because you marry people that you have similar symptoms or, but there might be some environmental factor. Okay, so the other thing that we know that increases people's risk for having IBS is infection. So there's a lot of data, this is a meta-analysis on if you have gastroenteritis, increasing your risk for having IBS, and it increases it's about a 10-fold increase. I think if you look at IBS in general, probably only about 10% have post-infectious IBS. We changed the term in Rome 4. We changed it to post-infection IBS because it's not really infectious. It's after an infection. So there's definitely an increased risk. And I'll tell you a little bit more about the risk, but I'm sure everybody in here has had a GI infection or food poisoning, but not everybody in this room is going to have post-infection IBS. And so there are multiple risk factors, and it's a younger age, being a woman, having a more severe diarrheal illness, having stress at the time, or having anxiety or depression at the time. And I think it's just that causes less, more healthy type of engagement of the systems to downregulate that infection and at least the sensitization of the brain-gut axis. But this is a study that showed this is an example of an integration of genetic factors and non-genetic factors. So you have these genetic polymorphisms that do increase your risk of having post-infectious IBS, and they include SNP genes that are involved in pattern recognition, immune function, and tight junction protein, because there is some emerging evidence that at least in a subgroup of IBS patients, they have increased intestinal permeability, or what the lay public calls leaky gut. And that can lead to a lot of disturbances, but we're still studying that and trying to determine how that plays a role in IBS. And then chronic stress. Having chronic stress at the time that you're having the infection increases your risk to having IBS, and we know that stress can alter gene expression. So it's not altering your genotype, but it's altering your gene expression. I really still feel this background. Do you guys still hear it? I don't know if it's disturbing anybody. Okay, maybe it's just me. Okay, okay, so I want to talk a little more about stress, which was one of the main areas I study, and I study stress because that's what I see in my patients. What's important to me is anything that's important for the patient. I try to study things that I think are relevant, that have some clinical significance. So if you look at this model that we've had for many years, there's likely a genetic predisposition, like I mentioned, and then you increase your risk factors, and like early life adversity is one of them. And something finally triggers the symptoms. And it could be psychosocial stressor, it could be an infection, it could be something physical. And then even if the stressor is gone, the symptoms become the stressor. The symptoms perpetuate the condition. And I think a lot of us think it might be abnormal the way a patient responds to their symptoms, but if you really think about it, I think it's protective. So if somebody is having some anxiety about going to a restaurant because they might have symptoms, I think it's protective. It would be strange not to have that. If you had incontinence and you're not worried about it, that would be abnormal to me. It's more normal, right, to be worried about it and try to do something about it. So they get symptom-related anxiety, and I think it's just protective, but it becomes pathologic because it amplifies their symptoms and it starts moving to more maladaptive behaviors rather than positive behaviors. So one of the areas that I study is, this slide, this happens. Okay, well, this slide is about early life events, and that's where you have some perturbation or traumatic event. Some people use under the age of 14 as childhood, and some people use under the age of 18. And this increases the risk for many different conditions. And you can measure early life adversity in different ways, but the way that we've been starting to do it is something called the Adverse Childhood Experiences Questionnaire. And the reason why I'm using it and we're using it is because this is the questionnaire that's been used in large-scale populations. So it started many years ago as part of the Kaiser population, where they get lots of questionnaires, and this is one of them, the ACE, the Adverse Childhood Experiences. And what they look at is, it's not just about abuse, physical, verbal, emotional, sexual, but it's also about neglect. That's an early adverse life event. And also any household dysfunction. So it's a little bit different than other questionnaires. doesn't say, did you know somebody that died in childhood? This asks about your household. Was there someone in your household that went to prison? Someone in your household that had mental illness, divorce, mother treated violently? So they ask about something close to you that could have affected you or stressed you. So they did these questionnaires in large studies, and this is the general population, right? This is the Kaiser population. And they found, and they wrote many papers about how having early life adversity will increase your health risk. And you can see here on the right that it's about behaviors. It increases the chance that you will have lack of physical activity, smoke, drink, miss work, and also physical mental health. It increases your risk for obesity, stroke, cardiovascular disease, pulmonary disease. But interestingly, they never studied GI disease in all of these studies, but it increased the risk, and it's graded. The more events you have, the increase your risk. So we actually studied it in our IBS population, which is a community population. I actually don't recruit for my clinic because there's a lot of confounders. So we studied this, and general trauma is pretty high because there's a fair amount of divorce. You know, it's usually like 40 or 50%. But in IBS, okay, so this is just irritable bowel syndrome. The main factors, or the main early life events that were adverse that increased your risk for IBS was having household mental illness and incarcerated household member, which there wasn't that many, but it was increased. Sexual abuse in multiple studies, including one I did before, is increased in IBS, but there's a sex difference. It's more in women than in men. Physical abuse or punishment's more in men than in women. And so in this study, and I think it was because of the sample size, it was just a trend to significance, but when you corrected for sex, that it went away. And then emotional abuse is always the strongest predictor. Sexual abuse also, but it doesn't affect as many people, luckily, but it affects too many people still. But emotional abuse is very prevalent, and that increases your risk for a lot of conditions, and but IBS being one of them. So if you look at stress, how do we study stress? And stress can affect cognition, your affect, your perception of what happens in your environment or in your body. And the two main output systems of stress are the sympathetic noradrenergic system, and also the HP axis, or hypothalamic pituitary adrenal axis. So we study those as part of a stress response, and they can affect gut function and immune function. But there are also corticotropin releasing factor, these stress hormones that can affect brain function and networks in the brain and that are not HPA related. So this is just some of the vulnerability factors that can increase your risk for IBS. So let's just talk now about some of the brain gut abnormalities that we see. I think this is an old study by Bill Che's father, William Y. Che, and I still show it because this is something that's very easy to explain to patients when they have diarrhea and postprandial symptoms. And that's where he looked at motility of the left gut, and he looked at IBS patients and healthy controls and then gave them a meal. And there's the gastrocolonic response, which I'm sure you guys all know, but that's amplified in IBS diarrhea patients. And that's, so if you distend the stomach, you stimulate that neural reflex to cause increased contractions or hyperreactivity of the left colon, and then patients get past gas or they have diarrhea. This is something very easy to explain to patients, and why you would give them an antispasmodic or why you would give them a tricyclic antidepressant with anticholinergic effects to try to blunt this response. So I think that's something very easy to explain. It's a little harder to explain constipation. And then I want to talk about pain. So why do we have pain, or why do these patients have pain? So if you say distend a balloon, and this is the way we used to measure visceral sensitivity, but it only modestly correlates with symptoms, and it's hard to get people to come in and say they want to balloon up their rectum and colon, so we were kind of like moving away from that. But we've done many studies, many centers. So if you do these distensions and you connect it to a computerized device and measure volume pressure, say, well, what's your threshold for feeling pain or discomfort? And that signal gets sent through these spinal afferent, and this is the dorsal root ganglion, and projects onto these dorsal horn neurons. Well, if you have repeated insults and you keep stimulating these dorsal horn neurons, they start going through a wind-up phenomenon. And we actually have silent nociceptors, and if you have a high intensity, repetitive stimulus, they will wake up. And now all of a sudden you're having much broader activation of these sensory nerves. And then it goes up the brainstem, and it projects to certain regions, but it also projects to the cortex, and of course it has to get to the cortex for a person to consciously perceive they have pain, and it goes to different regions. I was going to show you all the brain networks, but I thought we didn't really have time, so I'm going to keep it simple. But so when we get a stimulus, our brain then can, these ascending stimuli, we can also engage our descending pathways, and part of some of these pathways are from the cortex projecting to the main descending pain inhibitory control system, which is in the brainstem. It's in the pons. It's called the periaqueductal gray, the PAG. And from that, you have descending pain pathways, and there's three main pathways. There's the opioid, the serotonin, and the noradrenergic. And that's why you can think like why some of these agents work for pain. And they project down to the dorsal horn neurons, and they try to decrease the excitability. So some people used to use that gate theory, but they're trying to decrease it so you don't have so much incoming stimulus. But a lot of these brain regions, if someone's very hyperattentive, just like I told you, you can have symptom-related anxiety that I think is normal. It's protective. But the patient with an unpredictable condition like IBS, if you have it, you're thinking, am I going to have a problem right now? Maybe I can't do this. It's going to affect this or that. And so you become very attentive to, did I eat something that was bad? Am I going to have a bad day? You become very attentive to any visceral sensation. So that then you become hypervigilant. And you amplify those sensations. So now you have more pain facilitation and less engagement of pain inhibition. So now you have your balance is off. And that's what perpetuates chronic pain. So if we look at why SNRIs or SSRIs or tricyclics that work on serotonin and norepinephrine pathways, it doesn't just work on certain regions in the brain that are involved in autonomic control and pain, but they also engage these descending pain inhibitory pathways. But this is why I think that SNRIs are more effective as pain-reducing agents than SSRIs, because it works on 2 out of the 3 pain inhibitory pathways, and the noradrenergic pathway is one of the more robust pain inhibitory pathways. So that's more about the brain. And then we look at the periphery, and this is a lot of this is very, very hot, where people are looking at what are the peripheral factors that are involved in the pathophysiology. So it's not just gut microbiota, which we're really in our infancy and understanding, immune dysfunction, increased intestinal permeability, and a lot of these types of factors that play a role, bile acids. I personally do not think IBS is an inflammatory condition. I do think there's some immune dysregulation. I think the problem with IBS is that it's a heterogeneous group of patients, even though they all have symptoms of pain and some altered bowel habits. And so when you see any study in IBS, only a subgroup will have that abnormality. You'll never see it in everybody. And so there might be different factors that drive these different subgroups. And also, you don't know, is this an epiphenomenon or is this really meaningful in the pathophysiology and causing their symptoms? But mast cells are one of the immune cells that has gotten a lot of attention. And the thought is, if you have increased intestinal permeability or if you don't, that your immune system is more revved up and activated. And once it gets activated, like mast cells, it will degranulate, and these substances will act on these sensory nerves and cause them to be more excited, and you'll get pain or other symptoms. Or change in motility pattern. And so bile acids have been thought to be very important. This is a big area of research, and it's estimated that anywhere between 20 to 50% of IBS with diarrhea patients really have bile acid diarrhea, and you could treat them with a bile acid sequestrant. So it's something you could try. I personally have tried to use it, and I think it maybe works in 1 out of 5. I don't think it works, but that might be just my patient population. And then for gut microbiota findings, we know that there's decreased diversity, but you can see that in IBD also. So I think we still are trying to understand, is there a certain microbial pattern that's associated with IBS, but it's affected by diet, and a lot of these patients eliminate foods from their diet, or is there certain metabolites that we could look at that you don't really change the microbial pattern, but you change the metabolite production? So this is something that's really early that we're still studying. So getting to the clinical management, so we have the history and physical, and the history is everything in IBS. I actually really save the physical exam later, because it's usually, at least the patients I see where they've gone through multiple testing, is usually not going to be that, you're not going to find that much. You may be a little bit of mild tenderness. The history is the important part. The history of when they had symptoms, what were the vulnerability factors, and I always look at the time frame before the onset of symptoms and during a flare. Those are the two key points. And I look at the 6 months to a year before. So people are not so fragile that one thing will break them down. That's just not the way we're built. It's usually something repetitive that they may or may not be aware of that kind of is wear and tear in the system. And then maybe it's like the straw that breaks the camel back. Maybe it's something minor, but it's usually something going on for a while. You can see it happening, and then it happens. Now, once it happens, they're compromised. So even when they're better, they have, like I told my patient this past week, your buffer is going to be smaller. And so it doesn't take as much to stimulate the symptoms. And they're going to say, well, gee, I used to be able to do blah, blah, blah. But the thing is, now they have a compromised system. And even when they're in remission, it's compromised. So it doesn't take as much to trigger them. And that's something I think it's important to remember. Rectal exams are important for incontinence or for constipation, but I'm not going to get too much into it. So we talked about alarm features. Or we always talk about that, and I think these are important. A lot of IBS patients have alarm features, like say blood in the stool and it's really hemorrhoidal bleeding. We don't think they have colon cancer or IBD. So most of the alarm features, if they have it, usually doesn't show anything other than IBS. But if they have it, you want to be more aggressive in your workup. But the red flags to me are unintentional weight loss, waking up in the middle of the night to have a bowel movement. That's unusual. It's usually in the morning. And, family history, I think is important. So the ACG made some recommendations on diagnostic testing that you don't have to do so many different tests, waste money. But you want to do some of the standard tests here like CBC, chemistries. You don't really do stool, ova, and parasite unless you have a reason to think they may have had an infection, or abdominal imaging in people without red flags where you're not really suspecting anything. In fact, one of the AGAs, choose wisely, one of them was do not repeat an abdominal CT scan in a patient with chronic abdominal pain if there's no reason to think there's any change. Because I just see people repeat it, and it just doesn't really make sense to do that, get radiation. For screening for celiac disease, it's recommended to do that in IBS diarrhea or mixed. Lactose breath testing, it's only if you're not sure that's really lactose intolerance. Breath testing for small intestinal bacterial overgrowth is not recommended in general based on the available data. And routine colonoscopy is only done like you do every other patient in an IBS subject. You're not going to pick up more cancer unless they have red flags and you're missing something. But in a garden variety IBS, you don't do that. So there was a recent meta-analysis that came out from Bill Che's group where they looked at serum and fecal biomarkers. And I think this has been helpful. So if you have a low CRP or normal CRP or low fecal calprotectin, there's a less than 1% chance they have inflammatory bowel disease. And a lot of people don't like to give their stool, even when they have diarrhea, which is kind of amazing, but it's easy to get a CRP just to make sure it's not elevated, because an IBS is not going to be elevated unless they have something else going on. And you can also get fecal calprotectin. But this meta-analysis showed that an ESR was not helpful in differentiating IBD from IBS. So we have the new Rome 4 criteria. It's used more for research, but you can use it in clinical practice. What's different about Rome 4 than the previous iterations is this was revised based on normative data. So the general population, according to the US Census, in adults and kids, they were surveyed on all different questions about bowel habits and abdominal pain and bloating. And the thresholds for these diagnoses were based on those cutoffs. And the key was to have a little bit higher cutoff so that if you were setting this patient population, you knew you were getting them. It was more specific. But you were going to probably miss some of the people just because where you put the cutoff, but you didn't want to include healthy controls where maybe they just had some symptoms. And we took discomfort out because we and other people have done a lot of studies to show discomfort means different things to different people. But pain is pain. So you have to have recurrent abdominal pain at least 1 day per week. Used to be 2 to 3 days a month. 1 day per week on average for the last 3 months, and it has to be associated with 2 out of the 3 features. Same features we had before. The one that's different is related to defecation. It used to be improved with defecation. I'd have a bowel movement, I'd feel better with my pain. But there is a subgroup of patients that actually feel worse. They actually have more pain with their bowel movement. I don't know if it's because of the colonic contractions and sensitization. And then you have a change in stool frequency and then change in stool form. And a lot of people don't know that 95% of the general population have a bowel movement 3 days a week to 3 times a day. So they think, so some of this is a little bit of misperception or conception of what is proper bowel habits. But when you're outside of that normal range is when it's considered abnormal. The way we do bowel habit subtyping, and this is important if your treatment is for their bowel habits. If you're not, then it doesn't really matter. But first, it's based on stool consistency. It is not based on stool frequency. This is better than stool frequency, because you could have patients with hard stools going 17 times a day, but it's constipation, not diarrhea. It's all based on the Bristol Stool Form Scale, which I don't know if you use it, but I really, if you don't use it, I would use it because it's faster. You can, if you want, you can listen to the very long description of stool form, but this is a little faster. So, but it's based on the text. A drug company came some years later and added pictures because they thought pictures were good. But you really should read the text because if you look at 1 and 5, they look a little same. The key is that this correlates with stool transit time. So type 1 and 2 are the constipation stools, hard, dry stools. Stays in the colon longer, colon reabsorbs water. Faster transit, it doesn't reabsorb water as much, and so you're going to have loose, watery stools. So these are the diarrhea type, this is the constipation type. And it's the percentage of each of those bowel movements that determines if you're constipation, 25% hard, lumpy stools, less than 25% loose, watery stools. Vice versa for diarrhea, it's 25% or more are loose, watery, less than 25% are hard, lumpy. And if you have 25% of both, then it's IBS mixed. So that's how we determine that. So I want to talk about this blood-based biomarker for IBS diarrhea. Do you guys use this at all? So this is part of Commonwealth, and it based on some data from Mark Pimentel's group at Cedars-Sinai, looking at a post-infection animal model, and found that in this animal model that they had these increased antibodies to cytolethal distending toxin B, which cross-reacted with vinculin. So this is 2 antibodies, cytolethal distending toxin B and vinculin. And they studied it in the rifaximin trial. So even though they used a model of post-infectious IBS, they used a patient population in a phase 3 trial with recurrent use of rifaximin that were just IBS diarrhea. So it's not really post-infectious. And they compared it to a smaller number of IBD patients, healthy controls, and celiac patients. So here you can see the data, the optical density. So I think for IBS, it does separate from ulcerative colitis pretty well and somewhat healthy controls, although you honestly don't have to separate from healthy controls in clinic. Less so for Crohn's disease and definitely for celiac disease. So the sensitivity is only about 50%. So there's some people that are going to have IBS, but they're going to have a negative study. So you have to think about the psychological implications and try to explain that to the patient. If it's positive, it's more helpful. So it has a high specificity, but it has a lower sensitivity, just so that you know if you want to use it. I think it would be nice if it helped predicted who responded to rifaximin, but that's not been shown. Okay, so to talk about treatment, and just let me know when I have to stop. I think the way to think about treatment is to think about the severity and to think about the predominant symptom. That's the way I would focus it. So for mild, we all do reassurance, diet, lifestyle changes, explanation, education. When it's moderate is where you need continuity of care. If I learned anything from Doug Drossman on patient care, it's continuity of care. It's reinforcing. And you will see slowly over time that they start to self-manage, they start learning, they understand. That's where you want to get to. You want to get them to be able to manage their own symptoms. But that takes time. And so it's not a quick, easy answer. And for severe, I think the important thing to remember is that you may not reduce all their symptoms. You want to improve their quality of life. You want them to be able to manage and handle their symptoms better, not completely get rid of them. If they get rid of them, the bonus. But that's not really the goal. So if you think back on this model, well, what are some of the triggers if I'm trying to manage it? So we have food. So you're here with Jasmine Zia, so you guys probably all know about the low FODMAP diet and know that it causes symptoms because it increases water to be secreted in the small bowel, increases small bowel water content. And if some of those food products like fructans or fruits that have more fructose than glucose because they're co-transported, goes to the colon. We have more bacteria there. They ferment it. They cause gas production and colonic distension. If you give that to a healthy control population, you might have a little bit of gas, but if you give an IBS patient population where they have an underlying visceral hypersensitivity, they're going to report symptoms. So this is a randomized trial of a high FODMAP Australian diet, and it was 2 people in Australia that developed this diet versus a low FODMAP. It does show symptoms where you can see there's no difference in healthy controls on the right. But an interesting study came out in Gastro. This is done in Sweden, where they compared the low FODMAP to just a traditional IBS diet by the NICE guidelines. And that's basically eating 3 regular meals. Do not eat too much to get yourself full. Avoid onions and garlic. So part of it was low FODMAPs. No greasy foods, and try to avoid, I think, like alcohol. And so it was just, kind of recommendations that were thought to help to not overstimulate the bowel, and it was a very similar response. So I think in places where they don't have a dietitian to really spend time on the diet, the traditional diet was probably helpful, although there's some data from Bill Che that say that there is some advantage to low FODMAPs. So what about stress? Now I know that so trainees will come to my clinic and they're always hesitant. They say, well, I didn't ask anything psychological because I know you're going to go there. So it's kind of like Alice in Wonderland going down the rabbit hole, like I can't ask a question. I think it's really important to ask some of these questions, and it's not just to give you insight, it's to give the patient insight. Those symptom diaries, they're for the patient. It's not for you. You want them to learn how to identify their triggers, learn about their disease. So you want to know that there are some vulnerability factors that we talked about. I'd never directly ask about abuse. I just start kind of asking about their history. When they give me a little opening, I'll proceed a little further. I start very open-ended. Then I start focusing in try to paint the picture. But what I tell the GI fellows and I tell gastroenterologists, patients know that you're not a psychiatrist or a psychologist. So I think all they're looking for is that you acknowledge if those are meaningful to them or they're important. They're not asking you to fix it because they know that that's not really your expertise, but you might want to refer them to someone if it's helpful. So for the different treatments, I think about what these different pharmacologic treatments or behavioral treatments do, and I think about the symptoms and I use what I can. Did you want me to stop before I go to treatment and answer, or you guys probably want to only hear about treatment? It took me so long to get there. Or do you want? Okay. Okay, so this is what I say to make it simple. You have pain and you have altered bowel habits. Some of the treatments to normalize the bowel habit, which is lower hanging fruit, that's a lot easier to do. It doesn't always help your pain, but it's good to try. And then after you normalize their bowel habits, you see how much pain they have. So for laxatives, I think it's very reasonable to use an IBS constipation. This is only one study. It's been studying chronic constipation, but not IBS with constipation, pain with constipation. That's the difference. So basically the bottom line is PEG works well for bowel habits to improve stool consistency, stool frequency, but it doesn't help pain. But it's reasonable to try it first and then work on the pain afterwards. Okay, so we have 2 FDA-approved medications for IBS-C, linaclotide, lubiprostone. You can use it whether it's IBS-C or chronic constipation. That's constipation without pain or without predominant pain. There's 2 different doses. Honestly, you could use either dose. I always start lower and then I move up. I start lower because I want to make sure the patient doesn't have side effects. And a lot of times I'm transitioning them, and you can't just stop what they're taking. You have to transition. They don't like for you to stop because they'll go right back on it. And this is the data on linaclotide. I think the key point here with linaclotide, which I think is probably the most effective IBS-C or chronic constipation pharmacologic agent right now, is that it helps bowel habits quickly, like you see on the left panel, but the abdominal pain is slower. To actually cause desensitization takes a while. There's a lot of factors that play a role in pain. So what it's important to tell your patient is that you might have some improvement in your bowel habits, but it may take 8 to 12 weeks to maximize the pain effect. So I need you to stay on it to see if we can have a reduction in your pain. And what I do is I just titrate it. So there's 145 micrograms or 290. The FDA now allows you to dissolve it in water, drink half the cup. Drink 3/4 of the cup. You can titrate the dose according to their symptoms. For IBS-D, probably use rifaximin here. So it finally got FDA approved after this repeated treatment because the FDA knew that if you give rifaximin, you might have recurrent symptoms in 3 to 6 months. So they made them do a retreatment trial. It's a modest improvement, but it does help patients and some of the patients. So I don't use breath testing. There may be people that use it. I can't get really into that unless you want to really hear about it. But I just use it in IBS diarrhea patients, particularly with bloating, because I think it helps bloating. You probably don't use losartan here, so I'll skip that. So I'll talk a little bit about this drug, oxazolone, because it's new. So oxazolone is a peripheral opioid agonist and antagonist. So it's an opioid agonist like loperamide, but it also has a kappa agonist and a delta antagonist. It's thought to enhance the opioid receptors and make them less constipated too, to give it a little bit better balance, because people don't take loperamide because they feel they get too constipated. If you look at the data, the FDA requires in any IBS trial now, you have to use a composite endpoint. You have to have pain reduction and you have to have bowel movement improvement, whether it's stool frequency or stool consistency. Diarrhea, it's stool consistency. So this is the primary endpoint data. So there is an improvement over placebo. You can see the placebo is pretty low in these phase 3 trials because it's a little more strict than the old days. So it was FDA approved, but what I will tell you is that when you look at just pain itself, it wasn't as effective unless you had a greater reduction in pain. But the thing to remember about oxazolone, if you're going to give it to an IBS-D patient, there's 2 doses, 75 and 100, twice a day with food. It does cause, in their trials, sphincter of Oddi, or like sphincter of Oddi-like spasm. That's what they thought they had, right upper quadrant. So if somebody has that, or you think they had that history, you wouldn't use it. If someone had their gallbladder out, you would use the lower dose. Then they also had pancreatitis. And the pancreatitis typically happened in people that were drinkers. So if you have a patient that drinks at least 3 drinks a day, and some of you may not think that's really that much, but if it's more than 3 drinks a day, you're actually not supposed to use this because it can cause pancreatitis. Actually, okay. Then there's also something that a lot of patients like, that's what I want to tell you about. Do you guys know about IBGuard? So this is an over-the-counter peppermint capsule preparation. And there's data to show that peppermint that works as an antispasmodic, can reduce postprandial symptoms. That's the way I would use antispasmodics. It's postprandial. It's better that way. So they made this sustained release where it's released in the duodenum. So they think it less likely causes heartburn, but it still absorbs. So, but this showed in studies, if it's 1 to 2 capsules before meals, and if they studied 2 capsules, it reduces postprandial symptoms, and in addition to pain. So this is something very easy, but I will tell you just as a pearl that you don't have to take it before meals. They can take it when they have pain. Because if you took 2 capsules 3 times a day, it's almost $200 for over the counter. It's expensive. So patients, I tell them just to use it when they have symptoms. So you don't have to use it before meal. I guess if I was going out and I wasn't sure it's rich food, I would take it before, but you can just keep it and then they can take it. So just let you know. And then for antidepressants, I think that's what I would say about this is the low-dose tricyclics don't help mood, but they can help bowel symptoms and pain. And that you start a low dose, you move it up, and you have to tell the patient they have to wait, 1 to 2 months to have an effect. So the patient has to be patient about it, but you start lower to get less side effects, and they start acclimating to it, and then you increase it. So there's different tricyclics. SSRIs and SNRIs. SSRIs, NRIs just use at the dose you would use for depression. If you're really trying to get pain, use a low-dose tricyclic or use an SNRI. I really don't think the SSRIs work. I use SSRIs. They can be used for bloating. It helps because I think there's some anxiety with that. Or if you think that OCD or anxiety or any of those are driving their symptoms more than peripheral mechanisms. And for behavioral therapy, the one highlighted in yellow are the ones that have shown to be significant over a controlled arm. And what you're basically trying to do is you're trying to address their thoughts and their behaviors and make them less negative to more positive and increase the patient's perceived sense of control over their symptoms. So to summarize, functional GI disorders are multifactorial. Think about the physiologic mechanisms, think about the psychological factors of what you think is important in that particular patient, and look at their coping behavior. And then of the pathophysiologic mechanisms underlying IBS, they include brain-gut interactions like stress-induced GI dysfunction. So you probably know that the main stress this main stress manifestation in the gut is to empty both ways out. So it's going to cause delayed gastric emptying, nausea, vomiting. Someone's stressed, they're going to vomit, or they'll have nausea, or go to the bathroom. So it's really the body's way, I think, of getting rid of toxins. And I won't tell you about the mechanisms, but that's really a stressed response, the stress-induced GI dysfunction. We have altered motility, secretion, gut microbiota, and increased visceral sensitivity and permeability. And I think that pathophysiologic mechanisms are really going to be driving subgroups, and that's what we have to identify as researchers, like with Margaret Heitkamper and I are working towards that. Not everybody's going to be the same. And the diagnosis is based on symptom criteria and limited diagnostic tests. And your treatment decisions really should be based on the patient's symptoms. I think if you explain what you think physiologically is going on and why the treatment you're giving them is targeting that mechanism, they're much more likely to buy into that and take it and understand. And then I just listed the different types of treatment for the different bowel habit subtypes, and for pain and bloating, and for all bowel habit subtypes. So I think that's my last slide. I hope I made it in time. Thank you so much for your attention.